Hello, welcome to Nursing 411. This module is divided into three sections: cardiovascular assessment, EKG review, and ACLS. In this section of cardiovascular review, you will be looking at for a patient not in obvious distress. This is a cardiac review of a patient that is not in cardiac distress. Remember, a patient that is in cardiac distress, you will go directly into the focused area and you will treat the airway, breathing, and circulation. So, a patient who is not in obvious distress, you will review the patient's present illness, overview the patient's general cardiovascular system, review the general health status, and survey the patient's lifestyle, including his or her risk for coronary artery disease.
So this is what's going on with EKG. Not a very difficult topic, but there are some terminology. So we're going to start from the very beginning with some of these terminology. So you know with EKG, there's an electrical firing through the heart, right? So there are some terminologies you need to be familiar with. So one of the first terminology is what we call depolarization, also known as systole, also known as contraction. So we use these words interchangeably, right? So whether I say depolarization, systole, or contraction, it's all the same, right? So now let's go to the opposite end of that spectrum. Repolarization versus diastole versus relaxation. So the re and re, okay, helps you to remember that. But these words are used interchangeably. As you can see here in the PowerPoint, I have them, outlined right next to each other to tell you, okay, we use these interchangeably. So this is the beginning of the madness, right? So now I want you to think of the firing that takes place in the heart as a domino effect. So if I outline a whole bunch of dominoes here and I drop one, it's going to drop the rest. Okay, so this is similarly how the heart works. Okay, you need to understand what I'm doing now so that you can understand what happens. Where is this misfiring when we go over abnormal, okay, EKG? So the very beginning domino is the SA node. That's where that very first part of the firing starts place. And you've heard of that term, the pacemaker. So that is the beginning, the natural pacemaker of the heart. Once conceptions happen, if you did OB or you did health promotion already, because I know some of you are in school, that is the beginning part, right? SA node, that domino falls. After that domino falls, you can see the next domino is the AV node. And I'm going to show you a picture of the heart with the firing taking place because some of you are visual learners. After that AV node domino drops, it's going to drop what we call the bundle of hits. Now, the bundle of hits now branches, okay? It branches left and it branches right, okay? And at the end of those branches are what we call the Purkinje fiber. So that is the whole domino effect. Look at this picture here. You see the domino effect? This one, okay? You see how the SA node drops, the AV node drops the bundle of hits, and it surrounds the heart. Okay, so that is the firing, the electrical part of the heart. So think of the heart as that domino effect. Now, I'm going to go over 3 distinct waves for you on your EKG strip. But before I go there, I want to talk to you about the physical EKG strip itself. So your EKG, ECG tracings are these grid papers, right? It doesn't matter where you're from. We're all using the same grid paper. So if you decide, some of you are in New York, some of you are in Atlanta, I saw, it doesn't matter. We're all using the same grid paper, right? This grid paper that's in front of you. You need to know how to read this grid paper. Normally when you get your NCLEX question, you're given a 6-second grid paper, right? That's generally what we do. So your EKG paper, it's recording time. You need to know how much time is within your 3 distinct waves that I'm going to go over with you, okay? So if you look at this, what we did was we did a close-up view of what we call a big box. And within a close-up view of the big box of an EKG grid paper are 5 little boxes. You're going to see why you need to know this information in a moment, right? So within a big box are 5 little boxes. How much time are these 5 little boxes worth? That's what we need to know and remember. You're going to see why in a moment. So each little box, okay, is worth 0.04 seconds. So now each big box have 5 little boxes. So you have to do some math now. So we need to multiply, okay, 5 by 0.04. So 5 times 0.04 is 0.20 seconds, okay? So then each big box is worth 0.20 seconds. Why do you need to know this? Because we're gonna go over P, QRS, right? And you need to know how long is a normal P supposed to last, a normal QRS supposed to last, a normal P to R interval supposed to last. That's how you can tell you have a normal EKG. And then once we go over normals, we're gonna go over abnormal. We have to go over the AV blocks. We have to go over AFib, VFib, and all that. So first, we're gonna focus on a normal looking EKG, right? So in front of you is your grid paper. And we need to know time, you know, how much time is the norm for all of your distinct waves, okay? So as you can see here, there's P, there's QRS, and there's the T wave. So let's go over those 3 distinct waves, okay? And then we'll come back and show you a full, beautiful, normal EKG. So your first P wave, your first distinct wave is the P wave. What is contracting with that firing of the heart with the P wave? Your atriums. Your atriums are much smaller chambers. So when you do a full-blown NCLEX review, I go from the beginning. I go from scratch. I even go over the layers of the heart. I go over each chamber. I go over the valves. I go over blood flow throughout the entire body. You're just getting a piece of this whole thing, right? So your atrium, every time that contraction takes place, it shows up on your EKG strip as a P wave. The first picture you're looking at here is the beginning of the contractions of the atrium. Okay, the second picture, it's almost fully contracted. The third picture, it's fully contracted. You see how it's nice, beautiful, and orange, right? So that is the contraction of your atriums. Now, what's the next distinct wave? The QRS. Those are nice, big, large muscles, right? The ventricles are much larger than the atriums. So the fifth picture is the beginning of the contraction of your ventricles. Remember those words we learned earlier, depolarization? So this is depolarization, contraction of your ventricles, which shows up on your EKG strip as QRS. Now, the ventricles relax at one point and just sits there and receives blood, right? And that is another distinct wave that you need to be familiar with. So when the ventricles are relaxing, waiting for them to be filled up, that is your T wave on your EKG strip. So those are for NCLEX, those 3 waves you need to be familiar with. Now you have to ask yourself, how long are they supposed to last? Okay, that's why we went over the whole, 0.04 seconds, the big box is 0.20 seconds. So now there are some things you need to memorize, okay? So if you look here, your P wave should not last. You see, amplitude is normally 0.05, so that's like a little over one little box, to 0.25 to one big box. If you have a P wave lasting longer than that in time, you have a block, and we're going to go over blocks in a moment, okay? So the moment you look at an EKG, you want to see, do you have a P wave? If you have a P wave, is it lasting the recommended amount of time it's supposed to last? I'm not sure if all of you have learned this word. There's a word called homeostasis. You need to be familiar with that word. Everything in life has a therapeutic amount. And I mean everything, okay? Too much sun, you risk skin cancer, right? Not enough. You don't process a whole lot of vitamins and minerals, right? Too much water, hypervolemia, not enough, hypo. You need the right amount. Some of you may argue money, but even too much of that, you're in deep doo, right? People with too much money end up a hot mess. So that's life. You need the right amount. And when you do a full review, I go over all of that because that also is very relevant when we talk about psych and your neurotransmitters. That's just life. You need the right amount. So your P wave is supposed to be at a therapeutic time range, okay? So now your QRS. How long is your QRS supposed to last? So you see here 0.08, so that's two little boxes, to 0.12. That would be three little boxes. So if you look at your QRS and it's lasting longer than that, then you have a block, okay? These are numbers you need to memorize, unfortunately, so don't downplay that. You do need to work on that and automatically commit these things to memory, okay? Now, your P to R interval. So literally, you're looking from your P to the middle of your R wave, right? QR is, and a lot of books tell you to stop right before the Q. That is absolutely correct. So here, normally those need to last between three little boxes to a full box. Okay, so you want to look and see, is that lasting more than a full box? Then you have a block, okay, which we're going to go over the blocks. Okay, so just to recap, you need to review your actual, grid and know that one big box is 5 little boxes. Every little box is 0.04 seconds. Multiply that by 5 is how we get the big box being worth 0.20 seconds, okay? So here's a normal EKG. So if I were to zoom in on this, okay, and take a look at my P wave, my QRS, my P to R, it's going to equate to what I just told you is the norm. So be able to ID a normal strip. Literally, I put the 29 strips here on the table, and I tell you, pull out normal sinus rhythm for me. You need to be able to do it like that. And you know there wouldn't be any treatment for that because this is normal. All right, now, the Brady. Brady means below 60, right? So Brady arrhythmia. So here's the thing with your Brady's. So you have some athletes who are naturally bradycardic. Literally, you take their pulse, it's less than 60. It's normal for them. So that's the deal with bradycardic. You only intervene and do something if there's signs and symptoms. So you have a bradycardic patient who's perfectly fine. They're looking at there's no signs and symptoms. You do nothing. Now, if there are signs and symptoms, your drug of choice is atropine. Now, a lot of time we have options, with medication and everything, but I'm always going to go over with you the drug of choice. Okay, our primary, first go-to. So you'll hear me use different words for that. So Brady, atropine, only if symptomatic. Okay? So very easy. And you see the strip. You see how wide your QRSs are? So the moment you take a look at a strip like that, you can tell, okay, that's a slow heart rate. Because if I were to count all my little boxes here between R to R, oh yeah, that's going to be a lovely Brady client. It's definitely going to be less than 60, okay? So now let's go over some blocks. So sometimes the blocks are on your NCLEX, so you need to be familiar with them, and there are a few of them. So the very first one is your atrioventricular block, first degree. I'm going to come right back. There's also second degree, but there is second degree type 1, and there is second degree type 2. Okay, and I'm gonna go over the difference between those, and then there's third degree, which is, you can't miss third degree. All right, so atrioventricular block, first degree. What's happening with that one? So earlier we went over how long your R2R is supposed to take, right? So when you check out this strip, if you look at your R2R, okay, they are, so your P2R interval, so start at the beginning of the P wave to your middle of your QRS or right before the Q, it's way bigger than a big box. Okay, that's a block. So if I were to zoom in on this one and look at my P2R interval, it's definitely more than 5 little boxes. Okay, so that's a first degree AV block. So otherwise, everything else is normal within this strip. You have a P, you have a QRS, you have a P, you have a QRS, you have a T, normal. But the problem is the length of the P2R is greater than it should be. A lot of causes for this, drugs cause this, rheumatic fever, endocarditis, an infection in the inner lining of the heart, degenerative disorders cause this. So a lot of different causes. So we would go and see what's causing it and treat the underlying cause for this. Okay, that would be your treatment. So now let's do second degree type 1 and not mix it with second degree type 2. Okay, I'm going to show you the difference. So with type 1, now when second degree type 1, you have irregular. What does irregular mean? So irregular intervals of P2R. So if I were to look at my R2R, they're not coming at the same time. So you have irregular intervals of P2R, and then literally this client drops a beat. Okay, no heartbeat. So until a P wave fails to conduct. No P wave, no QRS. Okay, so as you can look in the strip here, PQRS, PQRS, PQRS. Look how they literally drop a beat. Okay, so that's for second degree type 1. That's normal aging, unless there's signs and symptoms. There's nothing you need to do. It's part of getting old. But if they do have signs and symptoms, atropine. Why? Because we're still under our Brady, folks, right? We're under our Brady umbrella. So now let's look at type 2. So type 2, you have a normal EKG. There's no irregular nothing. You looked at EKG, PQRS. Next one, PQRS. Same time frame, same interval. It's a normal EKG, normal. And literally they drop a beat. Okay, you're looking at a 6-second strip, normal PQRST, normal PQRST. Intervals are the same. The time is happening is the same, and boom, no heartbeat. That is dead tissue. Okay, there is some dead tissue. There's some ischemia. We do need to intervene for that one. This client needs a pacemaker. Okay, so second degree type 2, pacemaker. Second degree type 1, if there's no signs and symptoms, we monitor, we watch. If there's signs and symptoms, atropine. Okay, so now let's go to third degree. You can't miss this strip, right? It's so, oh my God, something's wrong here. So third degree is usually post and myocardial infarction. So these are the clients who have these scar tissues post, these disorders. Obviously, if you count this, your P to your R does not equal, okay? P length does not equal R length, okay? They definitely for sure need a pacemaker for third degree. Okay, so remember, you need to know the treatments. Not only need you need to ID the strip. If I put them all in front of you here, you need to know, okay, that's how you treat this one. So third degree, they need a pacemaker, okay? All right, so now that was all of our Brady's. Now we're gonna do tachy. So we're talking heart rate over 120, right? But we're gonna do tachys with atrial problems first, just the atrium. So literally that's how you tell whether you're dealing with an atrial problem or ventricular problem, the P wave, the P wave, the P wave, because we're talking atrial, right? All right, so look here, this is sinus tachy, right? So we have some PQRs, but look how narrow. You see how close they are to each other? So sinus tachy, you have your, your PQRs here, but they're so narrow that it's not even really showing clearly. So what causes these? A lot. Your NCLEX exam causes these because anxiety brings this on. Exercising brings this on. Like, we went up the stairs this morning, Rose. We were a little bit tacky, especially when I haven't exercised since way before COVID. So, yeah, I've been saying it. I've even said I'm going to get a treadmill. It hasn't happened yet. I have a good excuse, though. I have a heel spur, so I always have to wear high heels. If I ever put my foot flat, there's a pain that shoots up. That's because I'm non-compliant, too. I'm not wearing my orthopedic boot like I'm supposed to. Oh, Lord. Yeah, I'm working on that. I'm like a horse patient. Terrible. I've left, it gets better for advice and everything. Yeah, okay. Focus, Darlene. All right. Hypovolemia, dehydration, will also cause this. We all bad patients. I mean, I'm guilty, totally guilty. So we fix this by looking at the underlying cause. Like Rosanna, you took the stairs too, Crystal? Mm-hmm. Yeah. So we sat down for a few minutes, caught our breath, get some water. We're back to normal. Nothing wrong with us. We're out of shape. But besides that, we're fine. So look at the underlying cause and do something about it. So now let's go to some serious stuff, right? All right. Supraventricular tachy. Okay, so what's happening with supraventricular tachycardia? There's a firing, there's a conduction. You know, that first domino drops, it goes back. We never want that. We need stuff to go in the direction it's supposed to go and to keep going. We don't need you coming back. Same thing with blood flow. Blood flow has its direction it's supposed to go. Please don't come back. So that's what's happening with this problem, okay? Your SVT. You have a firing and it re-enters the atrium, literally comes back. Okay, so that's what causes that rapid firing. Okay, it's like an extra drive. So of course their heart rate is going to be like 140 or greater. Okay, and that's what causes that narrowness. Drug of choice, adenosine. Okay, so that's our drug of choice. Give it IV push. Okay, for this, and this strip is very easy to ID, okay? So you can see here, this is the atrial problem happening, okay? So now, atrial flutter versus atrial fibrillation. I'm going to show you how to read those two, and you'll never mix them again, okay? So now, atrial flutter is the one that you will describe as a sawtooth. I can see why, okay? Because it looks like, you know, that thing we used to cut wood, like the sawtooth with the edgy, okay? So with atrial flutter, you have P waves. You have them. They're edgy, they're sharp, but they're there and they're visible, as you can see here in this strip. And with your atrial flutter, you have regular QRS. So if I were to count R to R, R to R, R to R, they're equal. That's what tells me they're the moment you see that and you see P, that's an atrial flutter. So two things you need to look in this strip. Do you have P waves? Yes, they're sharp. Are your QRSs regular? Yes, they are. Now let's look at fibrillation. There's no P waves there. I see wiggly lines. So here's the difference. Okay, so go back. Flutter has P waves, they're edgy. Fibrillation does not. It's lacking the P waves. And it's irregular. Okay, flutter was regular QRSs. Fibrillation, they're irregular. So if you were to count R to R, you see how the first R to R looks like it's about 3 big boxes. The next R to R looks like it's about 2 big boxes. The next, so you see that they're not regular. So that's the difference between atrial flutter and atrial fibrillation. So if I were to put these two strips in front of you, you ought to be able to look at them and tell me which one is which one. Atrial flutter has P wave, they're edgy, and your QRSs are regular. Atrial fibrillation does not have P waves. They're wavy lines, and your QRSs are irregular. Okay? So you'll be fine with those two. Don't mix them, folks. Okay? Treatment for both of them are the same. What is your biggest concern with both conditions? Both conditions put the client at risk, okay, for thrombotic events. You see my picture here? Nice big red clots, okay? You want to prevent that because these conditions put these clients at risk of that, and this thing travels. They don't stay still. It would be nice if they did. They don't stay still. They travel, okay? And we want to prevent them from even coming. Now, students, with these type of questions, pay attention of when. I need to know the time frame of when these signs and symptoms started. Okay, I'm going to go over the signs and symptoms with you in a moment. So less than 48 hours, am I dealing with an unstable or a stable client? Why? Because, and the reason I asked you for the why is because it helps you build critical thinking. So throughout my review, that's one of the things. Why? Why? You need to know why. So unstable clients, okay, I'm going to treat differently than a stable client. Okay, they're hypotensive, I need cardioversion, okay, immediate cardioversion. If they're stable, okay, they're tachycardic, I need the beta blockers. You need that whole family to come into place. When I talk about the drugs, I talk about them in family because it's just easier for students to understand. You'll see in a moment. Okay? Normal sinus rhythm, direct cardioversion, right? We do electrical, we do internal. We're going to go over that. Okay? So now, if these signs and symptoms started greater than 48 hours, you are definitely worried about these little blood clots, for sure. And they're going to travel. So we have to talk about some blood thinners. And if there's clots currently, I need to talk about clot busters. So we're going to talk about anticoagulants, okay? We have to. And you know warfarin, Coumadin is on your NCLEX is not going anywhere, ever, in my opinion. We'll see. But, I would say, nope, that drug is going to be there. It's going to be there forever. And, we need the heparins to come into place. So we're going to talk about all of that, okay? So, signs and symptoms. How do these clients look? What do they present like? Because that's what NCLEX does to you sometimes. They don't come out and tell you the condition. They describe. And because I see why they do that. Your client comes into the emergency room. They don't come telling you, listen, I'm having AFib. I'm having VFib. They don't. You need to know the signs and symptoms. And when we do diagnostic tests, we can confirm what we think is going on. So they're going to be dizzy. They're going to feel some palpitations. They're going to be short of breath. They can't go up no stairs like we just did this morning. They got chest pain. Okay? They're tired. They're doing nothing and they're out of breath. Okay? So these are some of the signs and symptoms you're going to see. Okay, again, I love this picture. The beautiful blood clot traveling. We want to prevent that from happening. Okay, so we have to talk about these blood thinners. Okay, so let's go there. So medication, blood thinners. And one of the most popular ones that we have to talk about is warfarin, Coumadin. Warfarin, Coumadin is what we call high maintenance. It's just a high maintenance drug. Okay, so number one, you'll come in, you'll see what the physicians will do. The client will be on both Coumadin, warfarin, and heparin. Okay, because what happens is warfarin takes a while to get to its therapeutic range. That drug takes a good 2-3 days before it gets to its therapeutic range. So you know Mrs. Jones is going to be in the hospital for a good 3-4 days, okay, when she's on that drug. So that's problem number one. It takes a while to get to its therapeutic range. Problem number two, it's high maintenance in the sense that I need to draw Mrs. Jones' blood frequently to see where this drug is therapeutically. And I need to teach Mrs. Jones some things about the food she consumes. Because the antidote, by the way, I have a whole list of antidotes you need to know for NCLEX. When you take the full review, you get the whole list of those things. So the antidote to Coumadin warfarin is vitamin K. The problem is there's so much that we eat that has vitamin K. So we need to teach Mrs. Jones that she cannot consume excess amount of vitamin K. The goal is not to tell her to stop eating anything and everything green, leafy, veggie. No. The goal is, Mrs. Jones, you on this drug. Now I have your therapeutic range, where I want it. I'm going to show you what that is in a moment. I need you to keep your same diet. Don't change the diet because I got her blood to be therapeutically on the diet that she's currently on. So if she now goes home and has some lovely spinach salads 3 times a week, we got a problem. So Mrs. Jones, please don't change your diet because your blood is at a therapeutic range for this medication right now with the diet that you're on. Okay, I'm going to come to Xarelto in a moment. Let's finish Coumadin. Okay, so whenever a client is on Coumadin warfarin, we use what we call the INR, okay, and that's the international one. So the INR, wherever you go, that's what everybody's using, right? Thank God. Wouldn't it be nice if they did that with a whole lot of stuff? Because we wouldn't need to remember what where is using. We're all using the same thing. Okay, and I wish we would get together with the drugs and just say, okay, we're going to use the brand name only or the generic name only instead of this. So yeah, that would be nice if I rule the world, right? So I don't, so we got to go to what's happening. So you need to memorize, okay, your normal INR. So the norm, we want it between 2 and 3. So Mrs. Jones is on Coumadin warfarin. We have to pull her INR. We want it between 2 and 3. If it's less than 2, she's at risk to clot. So the purpose, by the way, of the INR is to see the viscosity of her blood. Is it too thick? Is it too thin? No, we want it between 2 and 3. If it's more than 3, she's at risk to bleed. Okay? Either one is bad. Therapeutic. We want that normal homeostasis, right? So in addition to pulling the INR frequently, even if I discharge her this drug, I have to send a home health nurse, or she has to come back to the clinic. I need to draw her blood while she's on this drug, right? And I need to teach her, listen, these are a whole list of stuff you need to not consume excess amount of, even some medications that thin your blood you have to stay away from. That's why we said this one is high maintenance, okay? So, and In addition to that, the drug that's not high maintenance is Xarelto, which is great. Okay, and you need to know Roxaban, not Xarelto, because remember your NCLEX tests you in your generic names, not your brand names. So please be familiar with your generic names. Okay, don't say I didn't tell you. So now Xarelto is not high maintenance. Mrs. Jones, take this with your evening meal. We're done. You don't need to come for me to draw no blood. You don't need to stay away from certain food. Nothing. So we love that. Less maintenance. Okay. So I'm going over the regimen of what we use to treat, these conditions. So here's some more treatment. So we use the antiarrhythmics family. So let me deviate to form just a little bit here to teach you how to study for pharmacology. So one of the first things you want to do when you're studying for pharmacology is to know your drug classifications. Okay, so who's the head of this family? Okay, so your antiarrhythmics are the classification of the drugs you see underneath here. So amiodarone, okay, flecainide, abulazide, okay, pirfenidone. Those are all the drugs that fall under the classification of antiarrhythmics. Quinidine is one. So you need to know the drug class, and then you need to know the adverse effects of the class. So every family has a little drama, right? But none of us are perfect. So you need to look at that family and see for that family, what's the biggest concerns. And then you see another regimen we use are the calcium channel blockers. Not all, but a lot of them, the majority of them, and then Felodipine, okay, isradipine, nicardipine. We love that because the suffix help us to categorize it, okay? So those are the treatment that we use, like the cocktails that we use to treat these conditions. So here's another breakdown of your antiarrhythmic. So in addition to that classification, you have class 1, which blocks sodium channels. We have class 2, your beta blockers. Most of them end in alol. You have your class 3, which blocks potassium. You have your class 4, which blocks calcium. So when we do a full review, I break down all of these, subfamilies to you. But in general, whenever a client is on these drugs, you want to go ahead and put them on an EKG monitor. Okay, because we want to know what it is that they're doing to the heart, okay? So the beta blocker families are here. Your anticoagulants are part of the regimen. We just went over warfarin, Coumadin. We went over Xarelto. Here are some other ones for you. You've seen that beautiful Eloquest commercial. So I like to categorize things. So this would be the regimen we use to treat these clients, okay? So now let's go into hang in there for me, okay? I know that's a lot of information, and again, this is just a piece of what you need to do for a full NCLEX review. Okay, last time I did a free one, I did it on pharmacology, okay? And I asked you all, what should the next one be on? And the majority of you said EKG, so this is it. So I know it's a lot, but remember, this was a full class when you did your nursing school. It just is the nature of the beast. There's nothing you can do about that. All right, so now let's move on to tachyarrhythmias with ventricular problems, and then I'm going to see if everybody's okay, all right? Because the mode that I'm in, I can't see your chats and everything. All right, so tachyarrhythmias with ventricular impulse. All right, so now don't mix, okay? We're going to go over VTAC. I'm going to come back. We're going to go VFib, okay? And of course, we're going to go over systole, but you should be fine with that. All right, so ventricular tachycardia, VTAC. Obviously, those issues are dealing with the ventricles. And you see earlier with your atrial problems, we had some abnormalities with the atrium, but we had beautiful QRSs, right? So once you look at strips like that, you know the problem is not a ventricular problem. Okay, here, looking at this weird, this is how I describe these. So VTAC versus VFib, okay? So VTAC looks like these big M's, don't they? You can use to describe them however helps you, but for me, these look like big M's, right? The word T for tachycardia, the letter T, they're tall, aren't they? So ventricular tachycardias are tall. If you look at this, takes 1, 2, 3 big boxes, if you go from bottom to top. That's ventricular tachycardia. They're tall. Look at ventricular fibrillation. They don't take more than a big box. So that alone tells you how to differentiate these two. If I put these two next to each other, you'll be fine moving forward, okay? So let's start. VTAC, ventricular tachycardia. You have a rapid firing. okay, with very wide obvious. I wouldn't even call these QRSs. They don't look like QRSs. This client definitely has an MI. Okay, there's some dead tissue, some ischemia. Okay, now this is the thing. When you get a ventricular tachycardia question, pay attention. Does this client have a pulse? Why? Because your intervention with a pulse VTAC is different than a pulseless VTAC. Let me repeat that. Pay attention when you get a VTAC question, because you need to ask yourself, do they have a pulse or do they not have a pulse? Because your intervention, what you do, how you treat them changes. Okay? So your VTAC may initially start with a pulse, but you need to do something about this quickly, because it can rapidly go to a pulseless VTAC. So obviously I have more time if they have a pulse. But if you don't intervene, it's going to go to a pulseless VTAC. Okay? VTAC with a pulse, amiodarone. VTAC without a pulse, Polacodin. If you're not in the hospital, you call 911. Remember your CPR days? You get the AED, right? All right, so pay attention whether you got a pulse or whether you do not have a pulse, because what you do differs, okay? All right, you see this EKG, right? We go from VTAC to VFib in a moment. Now, VFib always pulseless, okay? VFib is always pulseless. So that tells you right there you're calling a code, okay? Always pulseless. There's dead tissue. Yep, there's a part of the heart that's getting no oxygen. How is it going to pump and get blood to your body, okay? So typically, VFib, ventricular fibrillation, evolves from VTAC. If you had intervened with the VTAC when they had a pulse, you wouldn't be here right now. But let's say you don't. Sometimes these things happen at home, nobody's around, right? And it will go into a ventricular fibrillation, which is always pulseless. We're always calling a code for this one, okay? Now, some students have told me in the past that's two side de point. This side is on your NCLEX, so I always want to remind you of this one. This is a unique one. It's due to electrolyte imbalance. So this one of the first things you'll see the physicians do is order a chem panel. Okay, I need to get a chemistry panel to see what your magnesium and your calcium are doing. Okay, usually for these patients, they're low, so we need to give them an injection, okay? So that's usually the issue with that. It's just you need to be able to ID that strip and know it's an electrolyte problem. All right, asystole you'll be all right with. All right, let's talk about AED when we talk about asystole. So when we do an automated external defibrillator, and then you set the client up, and the machine tells you, clear, everybody clear, and you're supposed to say, clear, everybody clear, because if not, and you touch this client, you too are going to get shocked, right? But if the client is already in asystole, you're not going to get the direction, okay? And the machine is not going to shock, because your AED needs a rhythm. It may be an... Okay, there we go. Let's pull it up here. And I'll have to go back to that slide. That's okay. All right. So we just have a few more abnormals, and then I'm just going to remind you of some things, and then we will be done. Okay, so there are a few strips that just don't, fit under either category, whether it be grade E or tacky. They're special, right? They're unique. So those strips are just as important, okay? There's been questions on the NCLEX about PVC. Okay, premature ventricular contraction. The name tells you a lot. Students start paying attention to names, because names tells you a lot, okay? So obviously it's abnormal, but it's a premature ventricular contraction. So it is happening in the ventricle, but it's happening prematurely, okay? So if the client has no symptom, you don't need to intervene, but we do need to watch this client, because sometimes your PVCs can progress to ventricular tachycardia that we just talked about, or even worse, ventricular fibrillation, which is deadly. So we treat them if we have more than 6 of them, within a 6-second strip, if they're symptomatic, okay? But if they're not, we don't bother. Okay, so there's a couple of other things you need to remember for this real quick. So your ST elevations are important, okay? So because we want to make sure that these clients are not about to have, NMI. So we take them very seriously, okay? Because they're blockage to the supply of the heart. We want the heart to get blood to the heart pumps blood to the entire body, but it too needs blood. So we always want to check out the coronary artery diseases, make sure routes, make sure they're not blocked, because that. So the electrolytes very much impact how your heart functions. That's why when I found this little PowerPoint, I was like, okay, this is pretty cool. So you see the normal. Now pay attention to your T wave, because remember with the T wave, it's repolarization. The ventricles are relaxing and just waiting to be filled with blood. If your electrolytes are abnormal, you're going to see some changes in your T wave. But let's do hypokalemia first. This is the vocabulary which I was telling you about. So there are some things, some knowledge, some information that needs to be readily available. Okay, so like I just said, hypokalemia, hyperkalemia, hypokalemia. So if you're not familiar with what electrolyte I'm talking about when I say kalemia, then that means you need to work on some fundamental stuff, right? So you have to be honest with yourself and do that. Okay, so here, hypokalemia will cause a long QT interval, like you see here in this picture. If you go from the Q, my goodness, that is so widespread. Obviously, something is wrong. It's the potassium that's too low. Now, when it's too high, remember homeostasis, okay? If it's too high, hyperkalemia, you're going to have that tall peak T wave, right? You've heard that. So that's the electrolytes. So that's why, protocol. We have protocols in the emergency room. Okay, we have protocol CBC, BMP, KIMPAC. We want those things because we want to see what these electrolytes are doing. Okay, hypocalcemia, you see a prolonged QT interval. So pay attention to your electrolyte and know, what the effect that they will have on your EKG strips. Okay. Now, what I do is usually when I do a full review, I go into the pediatric disorders and I go into.
Let's start with pulseless electrical activity and asystole. All right, guys, I'm going to introduce you to your first two rhythms. Sinus rhythm without a pulse is called pulseless electrical activity, and asystole. Guys, these are lethal rhythms. There's no cardiac output, no perfusion. The person is clinically dead. What do we need to know about this rhythm? First, PEA looks like sinus rhythm, but guess what? The patient does not have a pulse. So what do you need to do? You need to check for the cause. There are 4 H's that are going to come into the next segment and 4 T's that we're going to talk about in the next segment. You need to know about those what's happening. You need to fix it and then treat the rhythm. Okay, the rhythm is going to rebound. So first, asystole, there's no cardiac output, no life, no heartbeat. They have no rhythm at all. Pulseless electrical activity, let's look at that a little bit closer. What do you need? Epi. Epi every 5 minutes. Every 5 minutes. Epi Q 5 minutes. What else do you need for this? Once you've given your first epi, but how do you give the epi? We need something else. I'm going to put it in the middle here. You need 3 things: airway, IV, and then epi. Airway, IV, and then epi. What does that mean? Once the patient comes in with low perfusion, low cardiac output, no blood pressure, no pulse, you need to call the code, get the crash card, and then do what? Get your airway in. After you get the airway in, you want to put in your what? IV. Once you would have established that this is a pulseless electrical activity, it looks like sinus rhythm, but the patient does not have a pulse, then you need to give your epi. You want to give epi every 3 to 5 minutes. 3 to 5 minutes. And then you want to consider what? You want to consider the causes. That's right. There are 4 H's and 4 T's. We're going to talk about the H in the next segment. T, cardiac tamponade. What's the next one?
That's right, pneumothorax. So tension, pneumothorax. What's the other two? Good. I'm going to let you figure that out in the next segment. Okay, we're going to do something. What happens here? When you have tension in the chest cavity, what are you doing here? You're bagging this patient. You're trying to open the airway. If you feel that this patient, the air is not going into the lungs is not expanding, then you need to consider tension pneumothorax. After 20 minutes of dealing with this patient, then you want to consider to stop the code. What happens after 20 minutes, the body goes into a very acidotic state, and it starts to compensate and then start to fight against itself. So let's look at sinus rhythm, pulseless electrical activity again. PEA, pulseless electrical activity. You want to give epinephrine every 3 to 5 minutes. You would have already recognized that the patient has sinus rhythm on the monitor, but no pulse. You would have activated the code, open the airway, start bagging, have your ET2 stuff available. You want to put in an IV, very large bore IV. A good practice is you want to put it in both arms, because remember this cardiac output is going to, his vascular system is going to collapse, so you wouldn't be able to do it in a few minutes. Then you want to start your epi. You want to give epinephrine every 3 to 5 minutes. You want to consider your 4 H's and your 4 T's. You want to fix it. Fix it. Okay? You want to fix the problem. Once the problem is fixed, then the PEA may be resolved. Okay? So consider your collapsed lungs with your tension pneumothorax there. Asystole. Everybody knows the flat line. Everybody knows the flat line. What do you do for asystole? Asystole, you walk in, there's a flat line, the patient is not breathing, there's no heart rate, airway, IV, epi. But what do you want to do first? You want to do CPR. That is the difference between your pulseless electrical activity. Pulseless electrical activity, you want to go ahead right away and fix the problem. Okay, this person is not flatlined as yet. This one here, airway, IV, epi, CPR, airway, IV, epi. You want to do what? CPR. After you would have done this for about 15 minutes or so, you want to consider amiodarone. Remember, with amiodarone, there you have a standard dosage. You can go IV or IO, intraos. If you're going to give it, you're going to give 300 milligrams first. IV or intraos. You want to give 300 milligrams first. If you don't have any changes, the heart rate doesn't come back, you want to go ahead and do 100. Your second dose would be 150 milligrams. Okay? So that is very simple. Again, with asystole, this patient may have progressed from PEA to asystole. So what do you think is added in this algorithm? Yeah, your 4 H's and your 4 T's. Okay? You want to consider those. You want to fix it. This person is on an overdose, had ingested some opioids, and he's overdosed. You need to fix it. If you fix it, patient may come back. Okay, so our next rhythm is Brady. Brady is not as bad as our previous 2 rhythms, which was asystole and PEA. Now, in that previous video, I may have said 30 milligrams of amiodarone. Remember, it's 300 milligrams of amiodarone. Okay, just want to make that clear. Followed by a second bolus of 150. Now, Brady is not as bad unless it's unstable. Do you remember unstable? Remember, I told you you're going to have to remember this. The collapse method. When we talked about collapse last week, we talked about C for what? Chest pain. A patient that has chest pain is considered unstable. Then O. What is O? Low oxygen. A patient who is unstable may have what? Low oxygen. Then, of course, you have your lightheadedness. What is your other L for? Low blood pressure. So low blood pressure, lightheadedness, chest pain, low oxygen. Then we have A, P, and S. What is the A for? Anxiety and palpitation. And of course, the good old shortness of breath. And what is the E for? You could have elevated heart rate, or you could have decreased heart rate. But in most cases, when you are anxious, when you're compensated, you're going to have increased heart rate first. Okay? And then, of course, D, dizziness. Okay? So bradycardia is not as bad if it's stable. Stable, what do you do for stable? Nothing. You remember your athletes could have bradycardia, a person who's on beta blockers. So athletes, athletics, beta blockers. Okay, so you need to ask your patient, is he or she on any beta blockers? But if the patient does not say that they're having any of the signs that is related to unstable, then you just leave them alone. Now, what do we do for unstable? What is the drug of choice? Now you're going to hear adenosine and you're going to hear atropine. You're going to hear adenosine and you're going to hear atropine. Anytime you hear the word atropine, we know that's going to do what? Speed up the heart. When you hear about what? Adenosine, then you know it's going to do what? Slow down your heart. So when we talk about sinus tachycardia, hello, we're going to have adenosine. When you talk about bradycardia, we're going to give atropine. Now, atropine has a maximum dose of 3 milligrams. You have to remember that. Atropine has a maximum dose of 3 milligrams, maximum. Now, there are lots of reasons why a person would have bradycardia. Several of them comes right back. See, this is why you need to know your 4 H's and your 4 T's. These are reasons why a person will have bradycardia. Now, atropine is given in from 0.5 milligrams to 1 milligram. So you can start off with 0.5 to 1 milligram. But here's the trick. If your patient is very, 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 very sick, that means his heart rate is below 50, and he is showing signs of unstableness, we could say that this person is unstable. When that person is unstable, what do you want to do? You want to start with the higher dose, which is 1 milligram. So you can give him that every 3 to 5 minutes with a maximum dose of 3 milligrams. If the patient is stable, that's this patient here, even though you're not, he doesn't have signs, the doctor might say, you know what, I want to just get your heart rate up. Just give him something to bump the heart rate up. But remember, you don't have to do anything here. But if the doctor decides to say, you know what, you've been 53 too long or 48, before you become symptomatic, let me give you something. He's going to start on the low dose, okay? So consider this one alive. Anyone who's alive and well, this one who is dying, who's going to be dead, 1 milligrams every 3 to 5 minutes. Now, once you give the atropine every 3 to 5 minutes, the max dose, and that doesn't work, then you have another treatment. Notice I did not talk about bring out the defibrillator. The defibrillator is not in this algorithm. Okay? Atropine is in this algorithm. What do you want to do next? Transcutaneous pacing. Okay? Transcutaneous pacing. What does that mean? You put the pacer on the patient, and you could do it 2 ways. There's a pad that's placed on the patient's chest. So this patient, I'm going to do something here. He has the rhythm. There's a pause. He has the rhythm. There's a pause. He has the rhythm. He has a pause. Okay? What happens is when you put the pacer on, the pacer then does what? Comes in and kicks in the pause. So when this patient was having a heart rate of 1, 2, 3, because you're checking your R's, you're counting your R's. He's going at 30, and 1 R is equal to 10. So that's 30 beats a minute. Here comes the pacer. You set your pacer actually. So you'll set your pacer. If the patient goes at 30, but you want him at 60, the pacer knows to bring him up to 60. So in this case, I set it at 50, and look what happens. 1, 2, 3. Then the pacer kicks in. Now you have 60 beats per minute instead of 30 beats per minute. So we just looked at sinus Brady. Brady is slow. So now we're going to look at sinus tachycardia, and sinus ventricular tachycardia, SVT. Okay? So now, what is the difference? The difference between sinus V-tach and sinus tachycardia is 150 to 250. 100 to 150. So when you look at your patient who's in sinus tachycardia, you're looking at a rate of 100 to 150. Sinus V-tach will be anything greater than 150 to 250. Just like sinus Brady, you have the stable patient and the unstable patient. Your unstable patient, remember, is complaining of chest pain. You look at the oxygen rate on the measurement of the SpO2, that is low. He's complaining of lightheadedness, any of the above. He doesn't have to have all of the collapse. It could be anxiety, shortness of breath, elevated blood pressure, and yet dizziness. So what then is the treatment? For stable, any drug, any of your betas, blockers that reduces the heart rate, you want to give the patient. Okay? Your Procardia, your Amorodion, 150 milligrams you want to give. Sotalol, Lopressa, any one of the drugs that are beta block. The patient is stable. There's no complaints of chest pain or anything. The unstable now, let me get my different color marker here. The unstable patient, what do you want to do for him? You want to cardiovert. Now see? You want to cardiovert that patient. In your sinus Brady, we did transcutaneous pacing. For your sinus tax, we want to cardiovert. On your defibrillator machine, on the crash cart, there is a little dial. The dial switches from defibrillation to cardioversion. So make sure that you're not defibrillating a patient that is unstable sinus tachycardia. There is a number that you need to remember. You want to give 50 joules. That's what you want to start off. Anywhere from 50 to 100. So of course, if this patient is symptomatic at 100 and 120, we probably could start at 50. If he's symptomatic at 150, we don't want him to get into this mode. All right? We can give him the maximum, which is 100. But you could do it 50 and then 50 and see what happens. Most of the times, the doctor would stagger it. Okay? So you want to cardiovert. Just like your TCP, transcutaneous pacing, you need to sedate first. That's your job as a nurse. Sedate your patient, cardiovert, and then 50 to 100 joules, Joules, of energy you want to give the patient. Now, we didn't do a good job, and the patient goes into SVT. Now, in this case, we didn't find out what was the problem, but remember, anything that is metabolic can cause SVT. Anxiety can cause it. Problems in your atrium, which we're going to talk about later, can cause it. Fever can cause it. The first thing you want to do is fix the problem. What is causing this problem? Is it something in the atrium? Is it the fever? There are some things that we can do as nurses, but before we get to that, now we need to try and slow it down. So someone is simultaneously trying to fix the problem while we are trying to slow it down. So what do you think the medication of choice is? Is it atropine? Is it dopamine? Is it adenosine? That's what it is. Adenosine also has a maximum dose. So you want to give 6 milligrams first, followed by 12 milligrams. Okay? So you want to give him the 6 milligrams, see if that'll bring it down. Then you want to give the 12 milligrams. Adenosine is the brakes of the heart. Okay? Atropine is the brake release. Okay? So you need that patient to start rolling. This one we needed to stop. So we want to give 6 milligrams first every 3 to 5 seconds. Now, 2 things you need to do. Just like in any rhythm, you have to make sure you have your airway and your IV. Preferably in both arms. This is the tube, the IV tube. This is the tube going up to the IV bottle. Okay? When you push, this is not the bottle, the patient heart. Okay? What happens now is when you put the 6 milligram in, it stays right in the tube. It doesn't go anywhere. And you're trying to figure out why this patient heart rate isn't going down. You must flush 20 cc's fast after you give your adenosine. You want that to reach the heart. Fast flush of 20 cc's of normal saline. You need to do that fast. So, we looked at asystole and we looked at PEA, asystole and PEA. Then we look at bradycardia, stable and unstable, reminding ourselves about the collapse, unstable. Then we look at sinus tachycardia, stable and unstable. Then we looked at SVT. Now we're going to look at the big guys. That is ventricular tachycardia. Again, stable and unstable. Then pulseless VTAC. VTAC, stable and unstable. Then pulseless VTAC. Then VFib. The good thing about this is the treatment is defibrillation. Only in this point here, we're going to go synchronized cardioversion. But everything else, then to SAD's the point, okay? When you have your low magnesium in the body, okay? When potassium walks in, magnesium walks out. So in this case, the patient is having an MI. Remember last week, MI increased potassium, when magnesium walks out. This treatment is very easy. If your magnesium is low, you just need 2 milligrams of magnesium. But here's the trick. I'm going to show you this. It's going to sound crazy, but I want you to just sing it in your mind, okay? So I'm going to do this 3 times. So what did I just do? I shocked the patient, I put in the IV, and then I did CPR. So I shocked the patient, I put in something in the IV, and then I did CPR. I shocked the patient, I put in the IV, and I did CPR. Shock, IV, CPR. Remember that. Shock, IV, CPR. Remember that. Shock, IV, CPR. One more time, because it's 3 times. Shock, IV, and then CPR. And so, we're back again. VTAC, stable and unstable. Now, we're going to, in another lesson, we're going to look at, remember you have to be able to recognize these rhythms, okay? Everybody say defibrillate, defibrillate, defibrillate. These are the rhythms to defibrillate, all right? VTAC, that is unstable, pulses VTAC, and VFib. So, there is a strip that I'm going to show you later, so we can know what it looks like. So if you have a monomorphic, stable patient in your box, in your treatment box, you want to synchronize cardiovert. Again, before you synchronize cardiovert, you want to sedate the patient. You want to do what? You want to give 50 to 100 joules. This synchronized cardioversion is found on your defibrillator. All you have to do is look at the button, switch it over, make sure you're not defibrillating this patient. If the patient is unstable, the patient shows signs of collapse, unstable, then we go to polymorphic. We go to polymorphic rhythm. Now, remember my little crazy move just now? What is the treatment for unstable polymorphic pulseless VTAC? That means that it's VTAC without a pulse. VTAC without a pulse. Remember that before when we had sinus rhythm without a pulse? That was PEA. Now we have pulseless VTAC. What then is the treatment for that? Remember my rhythm. Shock, IV, CPR. Shock, IV, CPR. How many times? 3 times. So the first shock, you're going to start with 120 joules. This time is not cardio, but you have to be on the shocking mode. I'm clear, you clear, everybody clear. Shock. Doctor's going to say, or the person who's running the code, 120 joules. Then somebody's going to come and give an IV dose of epinephrine. 1 milligram. Every 3 to 5 minutes. So, 3 to 5 minutes, what am I doing? CPR. Circulating. Remember, this person is flatlined. There's no blood, no perfusion from the heart. Cardiac output is low. SVR is high. We need to do what? Circulate that epinephrine. CPR. So, after about 2 to 3 minutes, we're now back again to do what? Shock. IV. CPR. This time we're going to give how many joules, how much shock are you going to put on this patient? You're going to give 200 joules. Then, who's going to be given the IV? IV, 1 milligram every 3 to 5 minutes. Then we need to circulate it by doing what? CPR. Then the third one, shock, IV, CPR. What is the third shock? You want to stack it up. You want to give them a higher joules. 300 joules. Shock, IV, CPR. Shock, IV, CPR. So you want to give 120 millijoules, 200 joules, followed by 300. Push your IV of epinephrine every 3 to 5 minutes. Then you do a cycle of CPR. That's about 2 to 3 minutes. Then you shock again, and by the time you've done that, you're back to your epinephrine again. If the patient has not rebound, then you want to give him amiodarone again. You remember we give this drug before. 300 milligrams, followed by what? 150 milligrams, okay? And that will do your pulseless VTAC. Everybody's so afraid of this. These are the lethal rhythms. This is where a patient is probably having a heart attack. And a lot of people are afraid of the actual defibrillation process. It's so easy. Shock IV CPR. Guess what? Now we're going to talk about VFib. The easy thing about VFib is the exact same thing as pulseless VTAC. If you recognize what VTAC looks like, you check the patient's pulse. He has no pulse, but it looks like VTAC. That means he's pulseless VTAC. This patient needs to get shocked. When you look at the patient and he has the VTAC, when you look at the monitor, but he has a pulse, he's stable, sedate, synchronized, and cardiovert. Now, what happens now after a long QT? You remember your QP, QRST, okay? So PQ, right there, QRST, okay? So when you have a prolonged QT interval, it looks like this, okay? So this, when you look to see what VFibs look like, it's a long QT interval, rapidly going. This patient needs shock IV CPR. Now, because you have that IV in there, you're going to go ahead, you're going to draw some labs. The patient can either progress or digress to SADS the point. The SADS the point normally comes about when your magnesium is low. This is your heart. Your heart operates on electrolytes. What happens is when your heart, when your potassium level, remember one of the indications for a heart attack is increased potassium. In our last segment, we looked at one or two of the most lethal rhythms, your ventricular fibrillation and your pulsus vitac. Now we're going to look at the Brady's, which is the heart blocks, your heart blocks. This is where you will probably get your transcutaneous pacing, or the patient may end up with a pacemaker. So here now, this is so easy to follow, this little thing here. You have first degree heart block. The AV node is not working as it should. So the heart is it's going very, very slow. So first degree, second degree type 1, second degree type 2, and then your third degree, okay? So you have your first degree, second degree, and then your third degree. So there are two types in your second degree. So look at this, your first degree, what's happening there? In your first degree, your P wave is prolonged. It's greater than 0.20 seconds. Prolonged. Not only is it prolonged, it is a constant prolong. It's constant. So you see, just say this is greater than 0.2 seconds. Just say this is 0.25. You see that there? So the next P wave, so you have a P, then you have your QRS, then you have your P again. It's going to be the same 0.25, constant. All right? So your AV is not working as it should. It holds the impulse that it sends to the ventricle, but the ventricle is normal. It's prolonged. Your first degree is greater than 0.2 seconds. But look at this. This is constant, but it's same 2.5, same 2.5. The person's in first degree. Your second degree type 1, it's irregular. The second degree type 1 is irregular. Look at this. Your first P comes, then you have your QRS, right? Your next second P comes, you have your QRS. Your third P, a QRS, and then so forth, right? So what happens then, all of a sudden, then it drops, okay? It does not produce a QRS. And then it starts again, okay? Look at this here. You have short, I'm sorry, it's not short. Long, longer, okay? And then your QRS just drops off. There is no QRS. Then it does it again. Long, longer, QRS drops, okay? It's irregular, all right? In this second degree, type 2, it's constant. So if you have anything that's greater than 0.2 seconds, just say this is 0.25, 0.25 is the same size. This is 0.25, this is 0.28, 0.30, 0.34. You see? This here is constant. We're going to go with a number that's easy, 0.25. Then there is no QRS. It does not produce a QRS. Same thing happens again. Constant, 0.25, PQRS, then no QRS. Okay, type 2 is constant. Third degree, there's no relation between PQRS. You can't say it's going to be constant. So let's end with third degree. In third degree, you have a P, a QR, and the P drops off. Then you have another P, QR, P drops off. Then you have a P, QR, and then the P comes back home. The ventricles are repolarizing. So what you have here, P, drop off, P, drop off, P, P. So your P's are just dropping off. There's no relationship between your P waves and your QRS. No relationship. Unlike this one here, there was a relationship. You have like 3 sets of PQRS, then there's no QRS. 3 sets, there's no QRS. Then you have long, longer, longer, long, longer, longer, and then you have a drop off. But here in your third degree, you have your P, then there's a drop off of a P. A P comes back, then it drops off, and then you have a P again, and then a P again.